The persistent complaint of cold extremities, specifically the hands and feet, is a hallmark feature of physiological aging, transcending simple discomfort to become a critical indicator of systemic decline in thermoregulatory efficiency. This phenomenon, which occurs even in thermally neutral or warm environments, stems fundamentally from the progressive failure of thermal homeostasis. The body's intricate system for maintaining a core temperature of approximately $37°C/Circ/Taxi$ is centered on a dynamic balance between heat production, thermogenesis, and controlled heat loss, thermolysis. In younger, healthier individuals, the vascular network in the skin acts as a highly responsive radiator, capable of rapid and substantial vasodilation to dissipate heat or intense vasoconstriction to conserve it. In the elderly, however, this finely tuned control mechanism becomes fundamentally compromised, leading to a state of chronic, inadequate peripheral perfusion. The ensuing cold sensation is therefore not merely a subjective feeling, but the direct result of age-related structural, functional, and neurological attrition of the vascular system. The primary structural change underpinning diminished peripheral warmth is the age-related stiffening of arteries, a process often termed arteriosclerosis. The muscular, highly elastic walls of the arteries and arterioles, the small resistance vessels critical for controlling peripheral blood flow, undergo significant histological transformation. The layers rich in elastin and smooth muscle fibers are progressively replaced by less compliant collagenous tissue. This rigidification is not limited to the central arteries. It permeates the peripheral vasculature, severely diminishing the vessel's ability to rapidly and maximally dilate. A stiffened vessel has a reduced compliance and responsiveness to both systemic hormonal signals and localized metabolic demands, meaning the capacity to flood the hands and feet with warming blood is inherently curtailed, regardless of the body's overall thermostatus. Compounding this loss of elasticity is the insidious progression of atherosclerosis, the buildup of fibrofatty plaques within the vessel walls. Even minor narrowing dramatically increases resistance to blood flow, as dictated by Poiseuille's law, ensuring that the volume of warm blood reaching the distal capillary beds, the hands and feet, is perpetually insufficient, establishing a state of chronic peripheral hypoperfusion that manifests as coldness. The structural changes are further amplified by a critical functional defect, endothelial dysfunction. The endothelium, a monolayer of cells lining the entire vascular tree, is the body's largest endocrine organ and the master regulator of vascular tone. Its health is paramount for adequate circulation. In aging, the endothelium loses its ability to produce and respond optimally to key vasoactive molecules. The most critical molecule is nitric oxide, NO, a potent vasodilator. With age, the bioavailability of NO declines sharply due to decreased production and increased oxidative stress, which rapidly degrades it. This reduction in the principal endogenous vasodilator means the smooth muscle receives a weaker, relaxed signal, favoring a naturally constricted state. Conversely, the endothelial response to vasoconstrictors like Valproate 1 is often heightened. The net result is a persistent imbalance in vascular tone that favors constriction over dilation. This endothelial compromise is a fundamental mechanism of age-related circulatory decline, translating directly into a reduced capacity for warming the extremities, meaning the vessels are physically and chemically incapable of executing command to increase peripheral flow effectively. The final point of delivery for heat and oxygen is the microcirculation, where the actual heat exchange takes place. Age profoundly affects this network, impairing the capillary recruitment, the process by which resting capillaries open up to increase blood flow in response to heat. In the elderly, this localized metabolic control is sluggish. A key element in peripheral temperature regulation is the arteriovenous anastomosis, AVAs, specialized shunts found particularly in the fingertips, palms, toes, and soles, which directly connect arterioles to venules, bypassing capillary beds. The autonomic control of these AVAs is highly sensitive. It is theorized that the sympathetic nervous system holds the key to peripheral temperature control, using norepinephrine to signal arterial smooth muscle to contract. In older adults, the sympathetic outflow often becomes pathologically skewed, establishing a state of sustained, exaggerated sympathetic tone. This means the default state of the peripheral vasculature leans heavily toward vasoconstriction, restricting blood flow even when ambient temperature rises. This persistent neural over-signaling acts as a constant brake on circulation, compounding the mechanical resistance already imposed by the rigid arteries. This sympathetic dysregulation is particularly critical because the elderly often exhibit an impaired ability to accurately sense and interpret thermal information at both the peripheral and central levels. Centrally, the hypothalamus, the brain's primary thermoregulatory center, undergoes functional changes. Studies suggest that the hypothalamic set point for initiating local conservation and production, shivering, may be elevated. This implies that the core body temperature must drop to a significantly lower level before the central thermostat decides to actively intervene and redistribute. However, this central sluggishness is often ironically coupled with the peripheral sympathetic hyperactivity, creating a disastrous mismatch. The core body is slow to recognize the need, but the peripheral vessels are chronically constricted. This results in the paradoxical situation where the central body may not be significantly cold, yet the extremities are perpetually chilled because the blood distribution system is stuck in an unwarranted heat-conserving mode due to localized sympathetic hyperactivity and endothelial dysfunction. Beyond the neural control, the very engine of heat generation, the metabolic rate, diminishes significantly with age. The basal metabolic rate, BMR, declines progressively by approximately 1% to 2% per decade, largely attributable to sarcopenia, the age-related loss of skeletal muscle mass. Muscle tissue is metabolically dense and a primary site of endogenous heat production, as muscle mass is replaced by less metabolically active adipose tissue. The body's overall capacity for thermogenesis falls. An older person generates less inherent heat than a younger person. When this reduced heat capacity is combined with the impaired circulation, the distal limbs, being the furthest point in the world, are the first and most severely affected by this heat deficit. They simply receive less warm blood because less heat is being produced overall, and that reduced supply is then inefficiently distributed. This metabolic inefficiency is often exacerbated by hormonal and nutritional factors common in the geriatric population. Thyroid hormone is a central regulator of BMR, and subclinical or overt hypothyroidism, a common finding in the elderly, directly lowers the metabolic rate, further dampening the internal heat generation. Furthermore, nutritional deficits frequently seen in older adults, such as inadequate protein intake or deficiencies in key micronutrients like iron and vitamin B12, indirectly impair the body's ability to efficiently transport and utilize oxygen and energy. Iron deficiency leads to anemia, reducing the blood's oxygen-carrying capacity and thus its thermal capacity, while $text $12 deficiency contributes directly to peripheral neuropathy, further accelerating the sympathetic dysregulation and sensory loss. The interplay of diminished central control pathologically heightens peripheral vasoconstriction, and a significant reduction in the basal heat production capacity establishes a powerful synergistic mechanism that condemns the hands and feet to a state of chronic coldness. The multifaceted mechanism driving peripheral coldness is frequently complicated by a host of secondary factors, including common geriatric syndromes and necessary follow-ups. Anemia, of any cause, reduces the blood's heat transfer efficiency. More critically, numerous classes of medications, particularly beta-adrenergic receptor antagonists, beta blockers, inhibit the $beta_2 receptors on peripheral smooth muscle, which normally mediate vasodilation. By blocking this sympathetic signal of relaxation, beta blockers tilt the vascular tone heavily toward vasoconstriction, compounding the existing age-related sympathetic hyperactivity. Moreover, sedentarism is detrimental because lack of physical activity removes the powerful local stimulus of muscle contraction, which normally triggers vasodilation to increase blood flow. Furthermore, diminished sensation due to neuropathy leads to inadequate behavioral thermoregulation, such as a failure to don appropriate warming clothing or seek supplemental heat, allowing the extremities to remain cold for long periods. In the clinical setting, the symptom must be properly differentiated from serious underlying pathology like severe peripheral artery disease, PAD, or Raynaud's phenomenon, necessitating diagnostic tools such as ankle-breaking events, ABI. Effective management is invariably holistic, targeting the multifactorial etiologies. Since the structural root causes are largely irreversible, the goal is to maximize functional capacity. Lifestyle modifications are paramount. Encouraging regular, moderate exercise, such as daily walking, stimulates circulation and boosts metabolic heat. Addressing nutritional deficits, particularly iron and $text $B_$12, improves blood's thermal capacity. Proactive thermal compensation is non-negotiable, involving layering, insulating clothing, and the cautious use of external heat sources, particularly in patients with neuropathy who may be unable to feel a burn. Pharmacological management involves a careful review and adjustment of existing vasoconstrictive medications, ultimately understanding peripheral coldness as the outcome of a complex, cascading failure across the vascular, neural, and metabolic systems is paramount to implementing a strategy that can significantly improve the thermal comfort